Before you take your next blood pressure pill tonight, I want you to pause. If you recently walked out of your doctor's office feeling completely relieved because they told you your numbers look absolutely perfect, you might be sitting in a hidden risk zone that nobody has warned you about. Maybe that thought has crossed your mind before. Maybe it has happened to you, to your husband, to your wife, or to your aging parents. The truth is, what keeps a 45-year-old body safe can do silent, quiet damage once you cross 65. And it is a dynamic that a rushed 15-minute clinic appointment simply doesn't have the time to sit down and explain to you. By the end of our conversation today, you will understand how your blood pressure actually works at this stage of your life. But before we open up the data, I want to ask you something directly. I read as many comments as I can because they genuinely inspire future topics on this channel. If you are comfortable, share your age bracket below. And let me know, have you ever felt a sudden wave of unsteadiness or a quick moment of lightheadedness when stepping out of bed in the morning or standing up from your favorite chair? If that sounds familiar, you are going to understand exactly why that room begins to spin in just a few minutes. To see how a perfect number can create a silent threat in daily life, think about an active 73-year-old senior. Let's call him Arthur. Arthur was independent, loved spending his mornings working in his backyard garden, and still drove himself everywhere. He had been managing high blood pressure for years. Following the standard medical checklist, his team put him on a couple of daily medications. The goal was simple: force the baseline down to 120/80. Every single month, his clinical chart read a celebrated 122/74. Arthur trusted that number. He felt safe. But one sunny afternoon, after spending an hour weeding his garden beds, Arthur stood up quickly to grab his watering can because his baseline pressure was pushed down artificially low and his aging blood vessels couldn't pump blood upward against gravity fast enough. His system collapsed in a flash. The world went dark, and he suffered a severe fall right onto the concrete walkway, fracturing his shoulder. When emergency responders arrived, they checked his pressure while he was lying down on the grass. It read a beautiful 118/76. But the moment they helped him upright into a vertical position, it plummeted straight down to 84/52. That is a staggering 34-point vertical crash. His brain had been starved of oxygen the moment he stood up. Yet, the brief lightheadedness he had offhandedly mentioned during routine clinical visits before was just brushed off as normal signs of aging. He was simply told to rise slowly. No adjustments, no real tracking, just rise slowly. Arthur's shoulder eventually healed, but his independence never did. He became deeply afraid of his own backyard. He stopped driving, his confidence shattered, and his entire life shrank down to the short distance between his bed and his living room couch. In public health research, we have to look at this and ask a heavy question. How can a perfect chart reading do this to an active human being? When I first started reading these specific geriatric studies, I honestly expected to find one simple, straightforward answer. Instead, I found something much more complicated, a massive data gap that might be affecting you or someone you love right now without you even realizing it. This is exactly why this channel exists. I'm James Bennett. I spend my time digging through public health databases, medical registries, and peer-reviewed cardiology journals so you don't have to. I am a senior health educator, not a physician, which means my goal isn't to prescribe a quick pill or give you a standard waiting room pamphlet. My goal is to give you the deep, unwatered-down scientific facts in plain English, so you can walk into your next appointment equipped with the exact data needed to have a real personalized conversation with your care team. What you have been told is incomplete. For decades, the message has been simple. Lower blood pressure equals better outcomes. 120/80 is the goal. Lower is safer. And for adults in their 40s and 50s, that is largely true and supported by decades of general data. But something fundamental changes in the cardiovascular system after 70. And the guidelines most practitioners are still using were built on studies that were never designed to answer the question of what is safe for your aging body. Right now, I am not going to give you the target number yet, because if I give it to you now, some of you will write it down and close this video. And that number, without the context that comes before, it could be more dangerous than no number at all. You need to understand why your body at 75 is physiologically different from a 55-year-old's before that number can protect you rather than mislead you. When I first diving deep into these clinical archives, this next landmark study completely changed how I look at blood pressure targets after 70. In 2015, a landmark trial called the SPRINT trial enrolled 9,361 adults over 50, average age 68. An intensive group aimed for below 120 systolic. A standard group aimed for below 140. The headlines were enormous. Fewer heart attacks, fewer strokes, fewer cardiovascular deaths. Aiming for less than 120 became the main goal for everyone. Doctors wrote more prescriptions and increased medication doses. On paper, these idealized charts got a gold star. But here is what the major headlines never told you, and it is something that busy health appointments rarely have the time to sit down and explain. The SPRINT trial excluded patients with diabetes. It excluded anyone with a prior stroke, anyone with dementia, anyone with advanced kidney disease, anyone with severe frailty. In other words, the famous study used to set the target your doctor is chasing was testing less than 120 only in the strongest, most medically uncomplicated older adults in the pool. Not the average 78-year-old who is managing 3 different health conditions and taking 4 medications. It did not test the independent senior in our opening scenario, and in many cases, it did not test you. And the same SPRINT trial documented that the intensive group had significantly higher rates of dizziness, fainting, kidney complications, and falls requiring hospitalization. The cardiovascular protection was real, but so were the consequences. A separate trial, the STEP trial, China, 2021, 8,511 adults aged 60 to 80 produced nearly identical findings. Lower target group, better cardiovascular outcomes, and more falls, more dizziness, more kidney strain. A close look at modern data registries on aging shows this clearly. Those trials answered an important question, but they tested a group of people that does not represent most independent seniors living normal lives today. The guidelines built from that data are being applied to everyday people who were completely left out of the original studies. That gap between the research data and the actual individual in daily life, that is where real-world seniors fall, literally. Why your body after 70 is not your body at 50. 3 things change in your cardiovascular system over time that make this matter so much. First, arterial stiffness. Think about an old garden hose coiled in your garage for 20 years versus a brand new one. The old hose is rigid. It does not flex. That's a little like what happens to our arteries as we get older. When your heart pumps blood into stiff arteries, they cannot absorb the pressure wave the way they did at 45. Your body needs a slightly higher baseline pressure to ensure blood reaches your brain reliably, especially when you are standing upright against gravity. Second, baroreceptor sensitivity. Your blood vessels contain tiny pressure sensors called baroreceptors. In a 30-year-old, they detect a drop the instant you stand and signal your heart within milliseconds. In a 75-year-old, those sensors have slowed. If your baseline pressure is already pushed down to 120 and your internal sensors are slow, The drop when you stand up hits your brain before your body can fix it. That is what causes the room to spin. That is the sudden loss of balance we see in these vertical crashes. Third, medication metabolism. Your kidneys and liver at 75 do not clear medications the same way they did at 50. A dose calibrated perfectly 5 years ago may now be hitting harder, staying longer, pushing your pressure lower than the office reading suggests. A sitting pressure of 122 over 76 looks ideal on a chart. What it cannot show is what happens to that number the moment you become vertical. Here's what I want you to do tonight. 3 minutes. One thing, a home blood pressure monitor available at any pharmacy for about $30. Lie flat for 5 full minutes. Rest completely. Check your blood pressure lying down. Write both numbers down. Now stand immediately and check again right away. Do not wait. Write those numbers down. If your top number drops by more than 20 points or your bottom number drops by more than 10 points right after you stand up, you have clear evidence of orthostatic changes. That is exactly what was happening in that hidden vertical drop every single morning before a fall occurred. Write those numbers down. Bring them to your next appointment. Do not accept that's probably just age. Orthostatic hypotension is measurable, addressable, and often medication related. Your physician can act on it if they have the data. This is the test most doctors are not performing at routine visits. Now you can do this test yourself. Make a commitment to log these numbers tonight. Before I give you the target numbers, I want to share why this channel exists. It is because we believe older adults deserve the same high-level scientific facts that usually stay locked behind expensive medical journals. We don't want it simplified or watered down. We want to give you the real framework in plain language, taken straight from modern public health data. Clinical Insights is working toward 100,000 subscribers because every single subscription tells the platform that deep health education belongs in front of more families. More awareness means more families can have this conversation before a dangerous fall happens. If this video has helped you understand your body better, please consider subscribing and liking the video. It helps push this data directly to the next person who needs it. Now here is the tiered framework put together from modern geriatric data. Find yourself in it. Know your real number, not the number on your chart. The number that reflects your age, your physiology, your medication load, your fall risk, and your quality of life. If you are 60 to 74, active and independent, no significant chronic conditions, not on multiple medications, a systolic target of 125 to 135 is reasonable and well supported for your profile. If you are 60 to 74 with diabetes, prior stroke, multiple medications, or any pattern of dizziness when you stand, do not chase 120. A target of 135 to 145 provides meaningful cardiovascular protection without the fall risk your profile carries. More medications are not always more protection. Sometimes they are more dangerous. If you are 75 to 84 and relatively healthy, the evidence now supports 135 to 145 as the range associated with best overall outcomes, not 120. The research consistently shows lowest mortality in the moderate range, not the aggressive target built for the 55-year-olds in the original studies. If you are 85 or older or frail at any age, preventing falls is a higher clinical priority than an aggressive target. 140 to 150 systolic may be the safest zone for your physiology. I know that looks high compared to every pamphlet in every waiting room, but we are not treating a pamphlet. We are treating you. And one number almost nobody addresses, your diastolic, the bottom number. For older adults, I want that above 65, ideally 70 to 85. When diastolic drops below 60, blood flow to the heart during the relaxation phase becomes compromised. If yours is consistently below 60, even if your systolic looks fine, that conversation needs to happen at your next appointment. Bernard is 72. He golfs twice a week, no diabetes, no prior cardiac events, good kidney function, blood pressure running 142 over 84, and he feels completely well. His doctor wants to add a second medication to reach 120. But looking at the data, this next detail completely changed how many experts look at treatment. The risk of pushing Bernard into dizzy orthostatic territory heavily outweighs any small heart benefit at his profile. Bernard is still golfing. Gloria is also 72, same blood pressure reading, but Gloria has type 2 diabetes, one prior cardiac event, and reduced kidney function. For Gloria, 142 over 84 carries real risk, but 120 is not her target either. Her kidney function and diabetes create a perfusion profile. The aggressive target would destabilize. Gloria's target is 130 to 135, reached gradually with orthostatic checks at every adjustment. Same number walking in, different targets walking out, because we are treating Gloria, not the number on her chart. That is what know your real number means in clinical practice. What to do with your doctor? If your doctor has a target for you, I am not asking you to discard it. I am asking you to have a more specific conversation. Bring your home blood pressure log morning and evening for 2 weeks. Bring your orthostatic test results from tonight. Bring your symptom inventory, dizziness when you stand, unexplained fatigue, brain fog in the mornings. These are not simply the facts of getting older. In the presence of blood pressure medication, they may be your body telling you the number on your chart is not the number your physiology needs. Ask directly. Given my age, my conditions, and my medications, is 120 over 80 actually the right target for my body? A physician current with the research will engage that question, and the data you bring makes the conversation possible. Many health advocates ask why this information isn't standard. Why isn't every care team having this conversation with every person over 70? The honest answer is that official medical guidelines move very slowly. The research data is often years ahead of localized clinical practice. Rushed 15-minute appointments are frequently working from older frameworks that haven't fully caught up to what modern registries show. That gap is exactly why this channel exists. If this data gave you something your last appointment did not, please subscribe right now. Help us reach that 100,000 subscriber mark so the algorithm knows this information needs to reach more older adults tonight. Please like this video and share it with someone over 65 who takes blood pressure pills. Your share might keep someone's family member out of an emergency room. That is not an exaggeration. It is completely preventable. In the real-world scenario we discussed earlier, once Arthur's data was properly reviewed by his care team, they safely reduced his medication load. His pressure settled at a stable 138 over 78. His vertical drop normalized from 34 points down to just 11. And 6 months later, he was comfortably back in his garden, enjoying his independent lifestyle. That is what the right number achieves. Not the number on a generic pamphlet, but the number that keeps a senior active, thriving, and independent. You now understand something the standard 15-minute appointment has not made time to tell you. You know blood pressure targets are not universal. You know the landmark study behind the 120 excluded patients like you. You know the 3 physiological reasons your body requires a different framework. You know how to perform the orthostatic test tonight. And now you know the tiered framework that modern research supports for real-world seniors, not just idealized trial participants. You are not just a number on a chart. You are an individual with a specific body, a unique history, and a specific set of risks that deserve an individualized answer. Know your real number, and make sure your care team understands your daily vertical physiology, not just a sitting reading on an office chart. This content is for educational and informational purposes only. It is not medical advice, diagnosis, or treatment, and should never replace guidance from your doctor or healthcare provider. Please consult a licensed physician before making any changes to your diet, medication, or health routine. Until next time, stay close to the data, know your real numbers, and live wisely.